This is Dr. Edward Gaber. The medical term for fainting is syncope. Syncope is a temporary loss of consciousness with complete recovery afterwards. There are three major types of syncope: vasovagal, orthostatic hypotension, and cardiac syncope. Vasovagal syncope is from the autonomic nervous system, causing dilatation of blood vessels and slowing the heart rate. Lightheadedness, sweating, nausea or vomiting, blurred vision, and palpitations often occur prior to the syncope, but the fast heart-beating palpitation is not the cause of the fainting. Vasovagal syncope rarely occurs lying in bed, but may occur seated, but most often standing. A tilt table test can decide if syncope is vasovagal with about 90% specificity. Vasovagal syncope can be triggered by severe anxiety, by nausea, by prolonged standing, or sitting, especially in hot environments. But the elderly may have no warning signs or triggers. The return to full alertness after syncope may be slow if the loss of consciousness lasts over 60 seconds. Fatigue and nausea often occurs after the episode. It can also mimic a seizure, as jerking and urinary incontinence can occur. Dehydration may be contributory, but is not the cause of vasovagal syncope. Vasovagal syncope can also be triggered by coughing, straining at stool, urinating, weightlifting, laughing, or swallowing hard. These events trigger the vagus nerve, which then decreases the heart rate, or straining, decreasing the venous blood return to the heart. The carotid artery sinus at the angle of the jaw can be sensitive to pressure, causing heart rate slowing and vasovagal syncope. Also, stopping abruptly after vigorous exercise can cause it. You should take at least 5 minutes to slow your heart rate down gradually after vigorous exercise, as vasovagal faintness can occur if you stop too quickly. The second category is orthostatic hypotension. It is the most common cause of low blood pressure in the elderly and syncope in the elderly. Low effective blood volume from fluid pills, GI bleeding, low protein in the blood, or low salt volume in the blood from diabetics that are out of control can cause it. It also occurs from lack of increase in systemic vascular resistance, or the inability to increase heart rates when you are standing. Drugs that block the autonomic nervous system, like beta blockers, vasodilators, and Parkinson's drugs, can cause it. Alcohol blocks the autonomic nervous system. Also, patients with autonomic neuropathy commonly have this type of syncope. The drop in blood pressure with orthostatic hypotension is more gradual than the drop in blood pressure with vasovagal syncope, but a 40-point drop in blood pressure can occur within 30 seconds after standing in a rare patient. The usual drop in systolic blood pressure, however, with orthostatic hypotension is around 20 points or greater than 20 points within 5 minutes. We check the blood pressure for this drop at 1, 3, and 5 minutes after standing, but some patients can have low blood pressure 10 to 15 minutes after standing. With orthostatic hypotension, heart rates only increase about 10 to 15 beats per minute with standing, unless there's also dehydration or volume depletion. Orthostatic hypotension can occur 1 hour after eating because of the dilatation of blood vessels in the gut after eating. The third category is cardiac syncope. Cardiac syncope occurs from an irregularity of the heart, or very fast or very slow beating of the heart. Episodes of syncope can occur from ventricular tachycardia because of coronary artery disease, Wolff-Parkinson-White syndrome, long QT syndrome, Brugada syndrome, and the cardiomyopathies. These are the most dangerous types of syncope and should be diagnosed quickly. EKGs, Holter monitors, implantable loop monitors are used to detect these abnormalities. Also, cardiac syncope can occur from outflow obstruction of the blood flowing out of the heart. This can cause syncope on exertion and occasionally post-exertional syncope. But that post-exertional syncope, however, is the vasovagal type, and it is benign. Aortic valve stenosis, idiopathic subaortic stenosis, and pulmonary hypertension are examples of outflow obstruction. Patients can also have cardiac syncope from inflow obstruction with severe mitral valve stenosis or a large left atrial myxoma growth inside the heart. With cardiac syncope, the patient is usually pretty alert right after the episode, except in aortic stenosis. As a side note, carotid artery stenosis, or narrowing of the carotid arteries, is usually not a cause of fainting, as both the right and left carotid arteries in the neck would have to be blocked for syncope to occur. Syncope in these patients occur from sudden drops in blood pressure and not from a decrease in brain perfusion from carotid artery stenosis. The tilt table test is performed by tilting a fasting patient upright approximately 70 degrees within 10 seconds. The tilt table test is contraindicated with a history of recent stroke or heart attack or severe coronary artery disease or carotid artery disease. If a patient loses consciousness without a significant drop in heart rate or blood pressure or a rise in pulse, the patient has psychogenic syncope. With the first category we talked about, vasovagal syncope, both the heart rate and the blood pressure drops quickly. With the second category, orthostatic hypotension, the blood pressure drops more gradually and the heart rate stays about the same or maybe 10 to 15 beats higher. Potts syndrome patients on a tilt table have a very abnormal test, which I'll talk about in a few minutes. But let's look at some patients' visits and think about the three major types of syncope just discussed. A patient recently came to my office as a new patient. He was troubled by frequent episodes of near syncope. He was on blood pressure medications, including diuretics and Parkinson's disease medications. He checked his blood pressure at home infrequently and had not had a blood test in 6 months. I emphasized to him the need for him to check his blood pressure every day at home so that I could get a handle on his blood pressure and elegantly adjust his blood pressure medications. He was to fax me his readings once a week and call me right away if his blood pressure was low, too low, or running high. Also, I ordered kidney function tests, potassium levels, and magnesium levels, and I arranged for them to be done every 4 months. These type blood tests should be done 10 to 15 days after initiating ACE inhibitors, ARBs, or diuretics. And also, if there's any alteration in dosage of these medications. Diuretics will especially lower blood pressure excessively. Other blood pressure medications may lower blood pressure to a certain degree, but diuretics do not care and continue to lower blood pressure more and more. Also, low potassium levels from diuretics can lower blood pressure on their own. Magnesium levels are often low with diuretics and should be checked. The patient was also on Parkinson's medicines, which can lower blood pressure when standing quite precipitously. Another patient I saw in my office was a 50-year-old who was having near fainting episodes while driving. His stat EKG showed third-degree heart block with very slow heart rates. He got a pacemaker that day. I saw a very alert 88-year-old man in my office with rare episodes of syncope. When I deliberately, briefly pressed on his carotid artery near the angle of the jaw, his heart rate and blood pressure suddenly dropped and he nearly fainted. I told him he could call me Dr. Spock from now on. He was referred to a cardiologist who advised him that he did not need a pacemaker and that he should not turn his head severely to the right or left, or press hard when shaving, or wear tight collars. Carotid sinus sensitivity is not uncommon, and it is quite scary to note when the heart drops 3 seconds and pauses 3 seconds at a time from brief carotid pressure. But pacemakers are no longer advised. Another patient showed up in my office with weakness and a blood pressure of 80 systolic and a heart rate of 120. His stool was positive for blood. He was admitted and transfused for GI bleeding. A 30-year-old told me offhand that for years, whenever he coughed hard, he would almost faint. He was athletic and stocky. He had a high vagal tone, and I told him his symptoms were normal. The tilt-table test is not helpful in situational vasovagal syncope with increased vagal tone from coughing, urinating, and straining at stool or vomiting. A diabetic patient I have, often in poor control with neuropathy and loss of vibratory sense in the feet, was having faintness 10 to 15 minutes after getting out of bed to go to the bathroom at night. I advised support hose and midodrine and an alpha agonist and more strict control of the blood sugar. I have a patient who is 97 years old. She faints frequently when her blood pressure is less than 150 systolic. The literature suggests that patients over 80 should have a blood pressure between 130 and 140 systolic. However, I note that some patients need a higher blood pressure to function, or they faint. I saw a farrier last year with muscle spasms, low blood pressure, and syncope. He had been shoeing horses and hydrating only with water in the heat. He was admitted and treated with IV normal saline, and on discharge, I gave him my sports medicine regimen for working or playing in the heat. He was to drink 16 ounces of G2, which is Gatorade without sugar, before going out in the heat. Drink 8 ounces of G2 every 20 minutes. And then he should weigh in his underwear before he went to work and when he returned from work. And he should weigh exactly the same if he hydrated correctly. But for every pound he lost, he would drink an extra 16 ounces more of G2. Nuns tablets, NUUN, in water are an alternative to G2. For salty sweaters, people who note cakes of salt on their arms and forehead with sweating, Pedialyte in the same regimen may be necessary. We know that football players with all their equipment on can lose up to 10,000 milligrams of sodium an hour in the heat. Knowing this, I tell my patients, even with high blood pressure, to be aware and use salt and water when they're working in the heat. Salt tablets can be dangerous if not taken with enough water, so we don't advise them. They're like drinking seawater, which can actually dehydrate you if you don't have the proper amount of water with them. I saw a lady who fainted at church. She'd been standing for only about 15 minutes and the church was fairly warm. Support hose and more salt and water prior to church was advised, but we also noted that she had a low cortisol level from taking intermittent prednisone in the past. Daily hydrocortisone was advised, and it stopped her fainting. John F. Kennedy had Addison's disease, which is a lack of the body's ability to make cortisol. He had taken many steroids as a child. I saw a teenager who was having fainting or near fainting spells accompanied by fast heart beating when she stood up. Some days she had to crawl across the floor at her house to get from one place to another. She had POTS syndrome, P-O-T-S syndrome, postural orthostatic tachycardia syndrome, from autonomic dysfunction. These patients have near syncope, and 40% of them have loss of consciousness. Support hose, more salt and water, more exercise, midodrine, and Florinef can help these patients. Occasionally they need phosostigmine and low-dose beta blockers. Syncope can occur with POTS without the blood pressure dropping. The syncope occurs from decreased perfusion of blood in the brain, and the tilt table test shows only a slight or no decrease in blood pressure, but an increase in pulse equal or greater than 30 beats per minute from baseline, or a heart rate of 120 within the first 10 minutes. But anemia, hyperthyroidism, and dehydration must be ruled out. In future podcasts, I will discuss dizziness or true vertigo as distinguished from syncope. Also, loss of consciousness from seizures, transient ischemic attacks, alcohol intoxication, low oxygen or hyperventilation syndrome are not classified with the diagnosis of syncope. Syncope lasting over 5 minutes is more likely low blood sugar or a seizure, but can be from aortic stenosis as mentioned. Confusion after the episode mostly indicates that the patient has had a seizure, and this post-ictal confusion can last for hours. I hope this discussion has been helpful. Always check with your primary care doctor or specialist before taking to heart any of my recommendations.